Good afternoon, everyone, and thank you very much for the organizers to invite me for this very interesting workshop and also to invite me to speak today. So my name is Luise Mueller and I'm an epidemiologist at the National Public Health Institute in Denmark. So I'm not an expert in the health surveillance of the Arctic, but I was asked to say something about human health surveillance, and that will be a little bit in general, and then with some examples from Denmark and my work in Denmark. So as Dr. Craig Stephen, I will start with a definition on the surveillance, because it's very important when you talk about surveillance that we know what we're talking about. So also the systematic ongoing collation and analysis of data and the timely dissemination of information to those who need to know in order for action to be taken. So the important thing is here that it's something that we do systematically and ongoing, as opposed to research projects, for example. We do it also in peacetime when nothing is happening, and we do it in the same systematic ways, preferably over years. And then the most important thing is that it's data for action. We don't collect data to collect data. We collect data for people to take action upon them. If we don't, then we don't do it. So what are the objectives of a surveillance system? Well, we might want to know the magnitude of a health problem of a specific disease. We want to determine the trends of a disease. Is it going up or is it going down? Detect outbreaks or severe events. We want to evaluate our control strategies. So if we set up a vaccination program, we need to know if the disease is actually also decreasing. Develop hypotheses about etiology and risk factors. Look at the different age and sex groups. Is it changing in somehow? We also want to detect changes in isolation, health practices, maybe even lab practices, and follow the microbial evolution, for example, antimicrobial resistance. And then we also have some international obligations in the European Commission and the World Health Organization with diseases that we have to monitor on the human side. So there are some things that we have to do, even though it might not be a threat for our country as such. So what are the criteria for choosing diseases to monitor? Well, ideally we would like to know everything. We want to have the full picture, but we don't have the resources to do that. So we have to prioritize. Of course, we look at the frequency. Is it something we see a lot? The severity, hospitalizations, mortality, but also long-term consequences of the disease. How infectious is it? How many people will be affected if somebody gets the disease? The costs, not only the direct costs for the healthcare and hospitalization, but also the indirect costs, for example, parents staying home to take care of their children while they're ill. So a small disease, as norovirus, just getting a little bit of diarrhea, it can affect, if it affects a lot of people, it can have quite severe costs because the parents have to stay home and so on. Preventability, can we do something about it? Do we have anything, a vaccine? Do we have something so that we are able to control it? We are also a part of a society, and we are also a part of public and political interests, and that also gives resources and money for specific things to look at. And then international relevance. We are not just a small country and we can't close the borders. We are definitely a part of a bigger society. So these are the things to bear in mind when you talk about your diseases and you try to set up a surveillance system in your country. In Denmark, I'll focus on now, we have basically two major surveillance system. We have a clinical notification system where the treating doctor sends in a notification when they see specific diseases on this list. And it's more than 30 diseases that we're monitoring this way. And then we have the laboratory-based surveillance systems where the laboratories at the hospitals, they send in also are notified via that. And that would be with our Danish microbiology database, which I'll come back to and tell a little more about. Then we have some other systems, childhood vaccination coverage system and some voluntary systems specifically on influenza. And I'll also tell you more about that in detail. So our microbiology database, MIBA, is, as I said, the backbone of our laboratory-based system. And it has all national microbiological test results. So when the laboratories in the hospital, they have a test result and they send it back to the doctor who asked for it, we will get a copy in this database. So it is real time, and we both have information on positive and negative results. So it allows us to make surveillance by data capture. And it's quite unique because we have this person identifiable data. We have the civil registration number. I'm from Scandinavia. We have this system, which also makes it possible to link to other registers. So it's quite good. I don't know how many of you are familiar with this, with looking at surveillance with what we call the surveillance pyramid. But usually when we look at diseases, we have a symptomatic population. Some of them might go to the doctor or an on-call doctor. Some might get a sample taken, being hospitalized, intensive care unit, and somebody might die. Usually when we talk about laboratory surveillance, we only see tip of the iceberg. So for example, Salmonella, we would only see those who come up here. The positive ones though, but up here. So we always look at it as an iceberg, that we only see the tip of the iceberg when we do surveillance. So when we in Denmark, we have 10 cases of Salmonella, why would we care? Yeah, because we know that we should times by 10 or something, because it's a greater problem than that, because there would be a lot of people down here that we can't count in our surveillance system. However, for influenza, we are trying to actually calculate the whole or estimate the whole surveillance pyramid, because influenza is a severe thing, and in Denmark we have around 1,000 to 2,000 deaths a year from influenza, and also the purpose is also to be prepared for a more severe type of influenza, pandemic influenza as resorted in 2009, and also to be able to detect if there's something different, if it's affecting another group of people, or if the vaccine, also to estimate the vaccine effectiveness each year. So what we have here is different systems trying to capturing all this in the surveillance pyramid. So for the top here, the deaths, we are looking at the mortality in our civil registration system. The intensive care units, we look at the Danish patient register and also for the hospitalizations. We look at which samples were taken in MIBA, and also we capture, by an electronic surveillance, we capture the contacts that we have from the on-call, when people contact the on-call doctors with influenza-like illness. And then we have some sentinel doctors. We have around 100 doctors each week reporting in how many cases of influenza-like illness they have by symptoms, and then they send samples as well. And then we also have some volunteers within the population, around 1,000 people, who each week report if they were ill the prior week with influenza-like illness. Then there are a group of questions. You get this questionnaire in your email every week. And all of these data are disseminated in our webpage timely. So this is an example from the Sentinel system that I talked about, where the doctors are reporting in. Now this graph shows the influenza season, so week 40 and up till week 20 the year after. That's where we monitor it. And the different years you can see here when it peaks. So we are looking at if the influenza season has started. This is this year and hasn't really started yet. But this is just an example to show how we disseminate it and how people can follow the trends and from all over the world actually. I'll zoom in a bit on the investigation of foodborne outbreaks because that's my key area of interest, and I'm working with that on a daily basis. In Denmark, we distinguish between what are local outbreaks and national outbreaks. So the local outbreaks would be point source outbreaks, for example, in a restaurant or a closed setting somehow. And national outbreaks would be cases in 2 or more regions, or if it has some kind of international aspect. The responsible institutions of the local outbreaks would be the regional food office and the medical offices, together with the local labs. And then for the national outbreaks, we're here, the State and Serum Institute, where I am, in the Department of Infectious Diseases, work closely together with our reference laboratory. Then we have the Veterinary and Food Administration and the Food Institute. Quite unique for Denmark, we have what we call the Central Outbreak Management Group, which consists of people from all these 3 institutions. So it's a One Health approach to foodborne outbreaks. We meet every week to discuss what's going on outbreaks in Denmark, and also to coordinate the investigation. And I'll give you an example on how we work with foodborne outbreaks and integrated surveillance in this One Health perspective, actually. And it's also an international outbreak. So this is an outbreak from 2017. It's a listeria outbreak from cold smoked salmon. Listeriosis is quite a severe disease in Denmark. We have around 40 cases a year. It's severe in the sense that it affects people that are immunosuppressed, elderly people and pregnant people. And the outcome would often be sepsis or meningitis. The fatality is quite high, around 25%. So it's quite severe. And as you can see here, it came to the newspaper and it says deadly as salmon recalled. So the first signal was on August the 23rd, where our laboratory reported about a genetic cluster found by whole genome sequencing of 4 cases. And then one of them was back from 2015 and 3 of them were from 2017. So that's the thing about listeriosis that we found out after starting whole genome sequencing, that we actually see some outbreaks lasting over years. On the 25th, 2 additional cases were identified. And this was, of course, discussed in the Central Outbreak Management Group, as I told you. And on the 30th of August, we compared the food isolates, or the isolates from food and environment that has been found in Denmark from 2014 up to 2017, and with the human cases on whole genome sequencing. And there was actually a match with the cold smoked salmon from Poland. We also interviewed the patients or the relatives of the patients and found out that at least for the 5 of the 6 cases we knew that they had been eating salmon as well. And the product was voluntarily recalled from the market. This is the timeline showing already from 2015, 16 and 17. There was 1 French case here, I'll come back to that. The 6 cases from Denmark were 4 female and 2 male, and there were no pregnancy-related cases. They were from 59 to 96 years old. All of them had underlying diseases, and 1 of them died within 30 days from the sample taken. And as you can see here, the product was recalled on the market here. So we made an international inquiry as soon as we found out this on August the 21st. We have different possibilities of doing that. We have the EPIS system, the European Epidemic Intelligence Information System under ECDC, which is a more informal forum where experts can write to each other. We see an increase of this. Have you seen anything like it? And we can share sequences as well, and they will look in their databases. We also reported at this stage, usually we don't always do it at the same time, but at this stage we thought that this was a very severe disease, so we also reported it to the early warning and response system, which is a system where we signed to inform each other about cross-border threats. And then the Veterinary and Food Administration, they also reported to the Rapid Alert System for Food and Feed, the RASIF system, about the specific product of salmon. So, to inform in Europe. And the day after, France reports back in these systems that they had one human case also related to this, and that was from 2016. And a few days after, they also report that they have a matching food isolates from salmon from the same producer in Poland. And the product was also recalled in France. And then a month later, 1.5 months later, Germany also reported that they had cases. This figure shows the results of the whole genome sequencing. And I don't know how many of you that are familiar with reading such diagrams here, spanning trees, but just to say that this over here is showing the comparison of what is called ST groups, so the co-genome, and with the same MLST called ST8. It's just it's a name, but showing that the red color is the Danish human isolates, the blue color is the French human isolate, the green color is the food in Denmark, and the purple up here would be the food from France. Those that are white and those that are grayish is ST8 as well, but it's not connected to the outbreak. So it's just to say that this is very closely related. If we zoom in, as we do over here, these figures here is showing something about the distance between the different isolates, and also shows that this is very closely related. So in conclusion, whole genome sequencing is a fantastic tool to be able to detect and also to compare between food isolates and human isolates, and also this cross-border comparison. So if we haven't had that, it's unlikely that we would ever have detected that this was an international outbreak, because France and Germany, they only had a few cases, so they would never have seen it in their trends in their surveillance system. 4 cases in 1 month in Denmark is a lot. We only have this 40 cases a year, so we might have seen something, but we wouldn't have been able to distinguish it from other listeriosis cases. So this is a very important thing. And then also to show that the communication on the platforms that we have are actually useful. We can actually use this ECDC platform to inform each other and get results back quite fast, so that we can investigate things together. So to sum up, I'll tell you about some of the challenges I see in human health surveillance. This about collecting data for action, I think it's very important that we have that in mind all the time. It's very difficult, I think, to prioritize what diseases to monitor, and we have to be very clear and discuss it, which diseases we select and why. We have to be able to expect and detect the unexpected. So how do we monitor a disease, an unknown, a new or re-emerging disease that we don't have in our surveillance system? So maybe we have to have some kind of syndromic surveillance also, where we know where we can also grab some of these things. Then to compare the surveillance data, I think I made it look very easy. It's not. You still have to have a common platform to to compare these things, and people still have different ways of typing isolates within their countries. So it's not that easy. You still have to have a good way of communicating. You have to also have new bioinformatics skills within the department, and this is also a new thing to have. But when it works, it's really nice to have the possibility also to look at humans and food isolates and compare it in a One Health approach. And harmonizing and comparing surveillance data across borders is also, I think, a very important point, especially also if you look at foodborne outbreaks, because the trade is just getting you get more and more that is served to or sold in a lot of countries at the same time. So you have potential some outbreaks that can be very huge, which we see all the time. Yes, that's.